Good afternoon, everybody. My name's Monica Slavin. I'm Director of Infectious Diseases here at Peter MacCallum Cancer Centre. And before we start, I'd like to acknowledge the traditional owners of this land, the Wurundjeri people of the Kulin Nation, and pay respect to elders and families past, present and emerging. So also I've got a couple of announcements. Please remember to look at the program for the upcoming talks. There's some very interesting speakers coming up in the program, and if you're interested, please register your interest for these next upcoming talks. Today, this is the VCCC meeting, and of course you probably all know it, but just to remind you, the VCCC is a powerful alliance of 10 successful Victorian organisations committed to cancer control, and its role is to coordinate collaboration between the member organisations and develop a strategic program of work that integrates research, education, clinical care to maximise patient outcomes in a cost-effective manner. So now I'd like to move on and introduce Professor Sharon Lewin. And we'll be hearing from Sharon today, who's the inaugural director of the Peter Doherty Institute for Infection and Immunity, a joint venture between the University of Melbourne and Royal Melbourne Hospital. She's Professor of Medicine in the University of Melbourne, a consultant infectious diseases physician at the Alfred Hospital, and a National Health and Medical Research Council practitioner fellow in Melbourne, Australia. Professor Lewin's an infectious diseases physician and basic scientist. Her research focuses on understanding why HIV persists and developing clinical trials aimed at ultimately finding a cure for HIV infection. Today she'll discuss the global role of partnerships in advocacy and health to find cures for chronic diseases and how this could potentially be applied to cure cancer. Presenting on the advances of our HIV cure being a result of significant investment in science, community partnerships, advocacy and global leadership, and how what has been learned from HIV story can be applied to other chronic diseases such as cancer, particularly in low-income countries. So it's a great pleasure to introduce Professor Sharon Lewin today, and please help me in welcoming her.
Thanks, Monica, and a great pleasure to be presenting. When I spoke to Grant about what I should speak on, should I speak on some work that my lab's doing, should I speak on cancer and HIV, which is where my major clinical focus, he actually encouraged me to present a slightly different talk and tell you the story about advances in HIV and why advocacy and partnerships have made such a difference, and how maybe some of those lessons could be applied to cancer. And I know that Grant's actually quite interested in that, given that immunotherapy is now a sort of simpler type of therapy to deliver, and whether there are ways that we can advocate as a community to make access to immunotherapy in low and middle income countries learn from what happened in HIV. So you'll sort of see where I'm going to go with this talk. I'm going to tell you a lot about what's happened to HIV over the last 30 years, a little bit about some of the drivers to that success, a little bit about the work that we do in cure research, and then try and link that back to initiatives that could potentially be thought of in oncology. So sort of thought-provoking talk, I hope. So for the older members of the audience, and I can see a few older members, they will think of this as the face of HIV. I'm sure many people, when I showed actually this picture to medical students, most people are not familiar with what this image represents, which A, makes me feel very old, but B, makes me realise how things have moved on. So this was the Grim Reaper. I'm sure many of you recognise the Grim Reaper in 1987. It was the face of HIV in Australia. Advertising gurus tell me it was the most successful health advertising campaign in Australia's history. Within 3 weeks of the Grim Reaper campaign, over 90% of people knew about HIV. Amongst the HIV community, this sort of campaign was very controversial because it totally stigmatises HIV, something that we've worked and still work hard against occurring. But nevertheless, people became very aware of it. What else did it tell us? It told us that HIV was a universal death sentence, which of course it was until the last 20 years, where the whole face of HIV has changed. And this is the front cover of The Economist. It's actually from 2011, so now getting a little old. But the whole issue of the conversation now is around whether we can really see the end of HIV, or at least the end of AIDS, which is an extraordinary advance in just 30 years. So how did things change so dramatically? They've largely changed because of tremendous advances in treatment, which arose from significant investments in science, I'll tell you about. Tremendous advances in prevention, and a very exciting news story from Australia, just actually announced in the last 2 weeks, of what's going on with new HIV infections in Australia. It certainly advanced because of very strong leadership globally, and that really happened because of advocacy. So patient advocacy in HIV is unparalleled. It's unparalleled because it wasn't just an issue around a disease, it was a political movement really in the early 80s related to gay rights, but that very much drove the advocacy in HIV, and actually continues in a different form now globally that I'll talk about. So just to set the scene, there are still 37 million people living with HIV globally. About 30% of those people don't actually know that they're infected. And in Australia, we have a tiny number of people living with HIV. The burden of disease is vastly different, where over 80% of people living with HIV are in sub-Saharan Africa, followed by West and Central Africa, the Asia-Pacific region. And although most people in this room, I think, or anyone in Australia thinks of HIV as a disease or infection of men who have sex with men, globally more women are living with HIV than men. And even in a country like the US, where HIV was predominantly an epidemic amongst men who have sex with men, it's now pretty much a disease of people of colour and of poverty. And the people with HIV, the dominant group living with HIV, sit within those risk groups. Australia has tiny numbers of people living with HIV compared to globally, about 27,000 of people living with HIV, one of the lowest in the world, which I'm going to explain why that happened. Treatment has been an extraordinary success story. Antiretroviral therapy can control HIV and has become simpler and easier to take. On the left is what people living with HIV used to take to control their virus, and on the right is what pretty much over 80% of people living with HIV in Australia now take. A single tablet, which is actually a co-formulation of 3 antiviral drugs. The drugs have got cheaper and widely accessible. So in Australia, the cost of HIV drugs is about $25,000 a year. But if you can access generic drugs in low and middle income countries, the cost is about $100 a year. And I'm going to talk a little bit about how we've managed to achieve this differential pricing costs in high and low middle income countries, which I think is probably very relevant for oncology. Treatment now has very minimal side effects, and life expectancy is now normal. And this just shows you the expected survival of a person living with HIV at the age of 20. If they became infected back in the mid-90s, life expectancy was about 8 years. Now, if someone, an HIV negative person, would have had an equivalent life expectancy of 60 years. And over the last decades, we've seen improvements in life expectancy. And ironically, in some areas, life expectancy of HIV is even, people living with HIV is even higher than people living without HIV, because they're plugged into healthcare systems that are focusing on prevention, cardiovascular disease, malignancy, etc. And these extraordinary figures haven't just occurred in high-income countries, in low and middle income countries, many places are now reporting normal life expectancy of people living with HIV. And this is all due to access to treatment. Treatment also has this extraordinary effect of blocking transmission. So when someone's infected with HIV, they have a lot of virus in their blood. We can actually accurately measure how many, literally, copies per milliliter of blood someone has. And in someone that's not treated, there is around 100,000 to 1 million copies per mil. You put people on treatment, the amount of virus in the blood actually lowers down to what we call undetectable. It's still there, but it's at less than 50 copies per mil. And we now know that once you have an undetectable viral load, your chance of transmitting virus sexually is actually 0. So many of us for a long time have said to patients, when you're on treatment, your chance of transmitting virus to another person is low, it's close to 0, we can't say it's 0. We recommend you still use protected condoms to protect the risk of transmission. And on the basis of randomized controlled trials as well as large observational studies, we actually know that this risk of sexual transmission is actually pretty close to 0. And in fact, no transmissions have really been recorded of someone that is on antiretroviral therapy. So we actually now tell people the risk of transmission is 0. So you can understand that increasing access to treatment has a double benefit. It keeps people alive and dramatically increases their life expectancy. And at the same time, it has a public health impact of blocking transmission to uninfected people. So the more people you can have on treatment in the community, the bigger public health impact you can have. And this is often called treatment as prevention. So there's a double driver to get more and more people on treatment. And indeed, this is happening globally. As a result of changes to how drugs are priced in low and middle income countries, generic drugs or generic antiretrovirals became available in about the early 2000s, which is why now, if you have HIV in India, cost of treatment is $100 a year. If you have HIV in Australia, the cost is $25,000 a year, which of course our government fully subsidises. And there's been this tremendous effort globally to get more people on treatment, and are now estimated about 40% of people living with HIV globally are on antiretroviral treatment. And this has very much been driven by advocacy. I talked briefly about advocacy by the gay movement in the early 80s, but from about the early 2000s, there's been this global advocacy, particularly amongst low and middle income countries, of also demanding access to treatment. Most of people living with HIV live in low and middle income countries, so why should those life-saving treatments not be available to them? So an extraordinary success story around access, with 40% of people living with HIV now on antiretroviral therapy. And I like showing this slide because it's in memory of a wonderful clinician scientist from Amsterdam, Joop Lange, who actually unfortunately died tragically in 2014. He was on his way to Melbourne to the International AIDS Conference and was travelling in the plane MH17 from Amsterdam to Kuala Lumpur, and actually was one of the 6 people on their way to the conference who tragically died in that event. But Joop Lange is often credited for making antiretroviral therapy accessible globally, having once said, if we can bring a bottle of Coke to every corner of Africa, we should be able to also deliver antiretroviral drugs. And he said that in the mid-90s, and indeed it was true. People thought antiretroviral therapy is too complicated, too complex, too expensive, too hard to administer. It can never be done in a low and middle income country. And now it's being done with extraordinary success. Treatment has got simpler, which has helped, but there's been a whole infrastructure developed to allow delivery of antiretroviral therapy in the most remote corners you can possibly imagine. And as a result of that, we're seeing AIDS-related deaths continually decline. This shows you the number of people who died of AIDS, and for the non-medical people in the audience, the difference between HIV and AIDS is that AIDS is you've actually become sick from the virus, while being HIV positive just means you're infected with the virus. And you can see the number of people dying of AIDS-related deaths peaked in the early 2000s, even though treatment was available, at least in Australia and the US and Europe from the mid-90s. But it wasn't until treatment was accessible to low and middle income countries that we began to see global numbers of AIDS deaths decline. And you can see it's been a steady decline since 2000, all as a result of access to antiretroviral therapy. The little dot down the bottom at 2020 is the targeted goal that the world currently has to achieve in relation to AIDS-related deaths. It's a targeted goal led by the UN, or UNAIDS, the agency of the UN that basically advocates for HIV, a targeted goal to get to 500,000 deaths per year by 2020. And given that we're in mid-2019, it's not looking like we're going to get there. And the reason why we're not getting there is that this is a summary of what's happening globally, but declines are not happening equally everywhere. And on the right, although the details are a little hard to see, the different colours represent different regions of the world and what's happening to AIDS-related deaths. And the really striking outlier is the green line going up, as opposed to all the other lines either steady or declining. And that green line going up, meaning AIDS-related deaths, is increasing in Eastern Europe and Central Asia. So again, most people think of HIV in Australia as an illness or an infection amongst men who have sex with men. The second thing that people might think is, oh, AIDS or HIV is a problem in sub-Saharan Africa, which is true. But we have growing epidemics in different parts of the world. And one of them is in Eastern Europe and Central Asia, largely due to policies on drugs. And most people living with HIV in that part of the world are people who inject drugs. And the reason why HIV rates are increasing amongst those populations is because of the attitude towards drugs and criminalisation of drugs, and people who inject drugs not receiving health care. In contrast to what we have in Australia, where very early in the epidemic, access to clean needles was available, and we've had pretty much no HIV amongst our communities of people who inject drugs. So these benefits or success stories in HIV are looking good globally, but it's not happening everywhere. And so there are these global targets which the UN has set for people, for what was now commonly referred to as 90-90-90, or making sure that 90% of people are aware of their HIV status, 90% of them are on HIV treatment, and 90% of them are virally suppressed. And this would lead to fewer than 500,000 new HIV infections globally, as well as a reduction in deaths. And these targets are actually quite very, very good to not only sell the message of what we're trying to do in HIV, but it also makes governments accountable for what they're doing for HIV. And it's although it becomes a slogan that governments, or a commitment that governments sign up to, and then make sure is appropriately funded. And if you look in Australia, we are at 90-90-90. We're one of about 20 countries to be at the level of treatment uptake, but we live in a very wealthy country with a fully subsidised public healthcare system. And so with no criminalisation of people who inject drugs or sex workers or people most at risk of HIV. But if you look around the world, other places are not doing so well. So if you look at global progress, not bad, I think. 75% of people are aware of their HIV status. Of those, about 80% on treatment, and of those, about 80% suppressed. But if you look at a country like Russia, about 45% of those on HIV treatment, and about 75% of them virally suppressed. And actually, having been to Russia just recently, I'm actually convinced that these data are probably not correct, and very few people are actually on antiretroviral therapy. Now, the other big advance in HIV, and again as a result of investment in science and advocacy and leadership, is around prevention. And we've always known for a long time that different interventions can reduce HIV transmission. And people now talk about these 3 pillars of prevention. So behavioural intervention, so we know that practices that lead to transmission of HIV, so modifying behaviour. Structural interventions, which is around alleviating poverty and education and women's rights. But things have really changed in the space of biomedical interventions. And some of the biomedical interventions that people think about, which many of you will know about, so condoms or safe sex was pretty much the platform for restricting sexual transmission of HIV. Access to clean needles is the platform to restrict transmission of HIV amongst people who inject drugs. PMTCT means mother-to-child transmission. So if you treat a pregnant mother for HIV, she will no longer transmit HIV to the baby. But the real changes have been in these 2 areas of testing and treatment. And so traditionally, when you used to go and get an HIV test, you'd go and see the doctor. The doctor had to be specially qualified to do an HIV test. They'd call you back and you'd have your results in 1 or 2 weeks. And so it was this very exceptionalised model of care. So you had to, because there was all these sensitivities around doing HIV tests in the early days of HIV, or the stigma associated with the fact there was no treatments available. So all that sort of exceptionalism around HIV testing has now changed. But in addition, there's been all these technological advances to get more people tested. And the first was point of care tests. So you can actually go to clinics across Melbourne and Sydney, get an HIV test on the spot and have the answer in 30 minutes. They're pretty good. They were only actually implemented over the last 3 to 4 years, while all across sub-Saharan Africa, point of care tests are the mainstream of diagnosing HIV. But a really big advance over the last 5 years, and only just happening in Australia since November of last year, was home-based testing. So just like a pregnancy test for HIV, people can now order a home-based HIV test. That's the website where you get it from, a Tomo test. They cost about $40. Their accuracy is pretty good, about 99.6% sensitivity and specificity. There's a lot of instructions in there. Should you get a positive test, to of course go and get it confirmed by a formal blood test, and therefore tap into all the services needed for care of someone living with HIV. So there's been a really big push to try and destigmatise testing as many people as possible, because there's an intervention to make a difference, and now home-based testing. And although Australia was actually pretty late in introducing point-of-care tests and home-based testing, the number of people having HIV tests has significantly increased. The other major advance is something called pre-exposure prophylaxis, or PrEP. And this is a medical way to reduce your risk of getting infected with HIV. Literally 1 pill a day, which is an antiretroviral drug, similar to what someone would take if they're being fully treated for HIV. They're on 3 drugs. You can take 2 drugs to prevent getting infected with HIV. And this was proven to be extraordinarily successful, reducing your risk of getting HIV if you take those preventative medications or PrEP. Your risk of acquiring HIV is reduced by 99%. It's as effective as the oral contraceptive pill. And it was actually shown initially amongst gay men, published in the New England Journal in 2010, but it's taken almost a decade to get that into routine public health practice. And the reason why it's taken so long is complex, but it's also cost, because this is a pretty expensive way to prevent HIV. It'd be much better if we just had a vaccine, for example. You also rely on people taking the tablet. There are some toxicities with the tablet. But anyway, discovery, the landmark study was done in 2010. Then there was this fantastic follow-up study done in France, published in 2015, showing that you didn't have to take PrEP every day to make it effective. You could actually take it, it's now called event-driven PrEP, meaning that you can take it 2 hours before sex and 48 hours after sex. You sort of got to know something's going to happen in 2 hours to know that you're going to take it. But I think most people have got a rough idea that, you know, it's leading somewhere 2 hours before. You take it 2 hours before, 48 hours after, it works just as effectively as if you took it every day. So we now have, and this is just two of about 10 different studies I could have shown you on the efficacy of pre-exposure prophylaxis. But yet to get it into a community or to get governments to pay for PrEP has actually been really difficult. And this is a great Australian success story because Australia was one of the few countries that decided to fully fund PrEP back in April 2018. And it came off the back of two what's called pilot projects, one that was in New South Wales led by Andrew Grulich and one that was in Victoria led by Edwina Wright at the Alfred. So we had a very good understanding of what the best ways to prescribe PrEP in the Australian context, to not have to have people going to big public hospitals to get PrEP, for them to get PrEP from their GP, to get it from a local pharmacy. So we had a lot of data of how PrEP could work in Australia, enough to convince the PBAC, the overarching body that determines drug pricing, enough evidence to say, it wasn't easy, I should say, went to PPAC about 4 or 5 times over about 5 years, but enough evidence to say this was going to be a cost-effective investment. And look at what's happened to the uptake of PrEP since April 2018. So launched by Greg Hunt, about 2,000 people were on PrEP through these demonstration projects, and then looking at December 2018, about 18,000 people on PrEP, probably the biggest number of people on PrEP globally. Estimated about 70% of people that are at risk or would benefit from PrEP are on PrEP in Australia. And the returns of that investment of treatment, of PrEP, of HIV testing is now beginning to show. And this is just data that was released 2 weeks ago from the Kirby Institute at University of New South Wales, who are responsible for tracking HIV notifications across Australia. And for basically the last 2 decades, we've had on average about 1,000 diagnoses of HIV a year. And you can see that in 2018, there were 835 diagnoses. It was a 23% decrease, and the first substantial decrease in new HIV diagnoses in decades. And I'm going to show a little bit of data about why and where this is happening. But I can tell you this is big news. This is last Friday in the New York Times, a full article about Australia's response to HIV, how Australia could almost eradicate HIV transmissions. They interviewed both Andrew Grulich in Sydney and Edwina Wright here in Melbourne. And I like this quote: it took universal healthcare, political will, and a health campaign designed to terrify the public. That was the Grim Reaper. But nearly 4 decades into the HIV crisis, Australian researchers say the country is on a path towards making HIV transmissions of the virus vanishingly rare. So really an extraordinary success story, paying off now what was actually started back in the early 80s. But what we now know is those decreases are not happening everywhere. So we're seeing a 30% decrease in men who have sex with men, but no decrease in infections in heterosexuals. And this is largely thought to be access to PrEP. Even more interesting, if you look at where people are born, 37% decrease in Australian-born MSM, stable in overseas-born MSM, showing that if you're born in Australia, perhaps you're more likely to be engaged in these communities that will be providing these public health messages, so you know about PrEP and you know where to access it. And similar to many other infectious diseases, unfortunately, I'm not seeing similar success stories in Indigenous communities. Rates of HIV in Indigenous populations are about 1.6 times higher than in non-Indigenous populations. And the epidemiology of HIV in Indigenous populations is actually very, very different, and targeted approaches will be needed there. So great story, I think, of what can be done. This just shows you where PrEP is being, the wide variation in uptake and funding models for PrEP and the number of people on PrEP. And you can see that, you know, North America and Australia have got high numbers on PrEP, but many, many countries in which PrEP is still not available. And of course, in a low and middle income country, these are really difficult decisions. Do you fund antivirals to prevent HIV, or do you fund antivirals to treat HIV? And in a country where you're not yet treating everyone with HIV, it becomes difficult to fund it for prevention, but they are interlinked. And in fact, you can, as a consequence of all these interventions, you can see it's a complicated slide, but overall, we have 1.8 million new HIV infections still globally. This has plateaued over many years. And if you look at the, I can't get my cursor to work here, but if you look at the map, many countries are reporting decreases. And I'll just highlight, I'll just bring out the highlights. Sub-Saharan Africa, 30% decreases in new HIV infections. Asia, 15% decreases in new HIV infections, largely as a result of increased access to treatment and in some places prevention. But in Eastern Europe, you can see the numbers of new HIV infections increasing. So Australia's had this fantastic success story, I think, on science and on clinical research and clinical care, but really on policy and leadership. And there was a wonderful article, actually, I don't know if many of you saw it, in Sydney Morning Herald last week, crediting Bob Hawke for sort of setting the scene for the response to HIV. And there has actually been this tradition of a bipartisan response. I think in the cancer world, it's probably not such an issue. Everyone always cares about cancer and it touches everyone's lives, but in a really politicized situation like HIV, you can imagine that there would be bipartisan, there'd be political differences about policies towards HIV. And in Australia, we've never really seen that. Both Liberal and Labor governments have really supported the response funding towards HIV, working with relevant communities. And in the US, similarly, actually, the Republican and Democrat parties have both been big supporters of the HIV response, even including the administration now. It's a little unusual what they're doing, like in everything, but their commitment to HIV funding is still maintained. And this is just a few of the kind of key leaders in the early days of HIV. Neil Blewett, who was the Minister of Health at the time, David Pennington, Alex Wodak, Michael Kirby on the bottom right around human rights, and Bill Botel, who is a very key advocate from the community. And it very much set the scene of how Australia responded to HIV even through to now, 2019. And then globally, you've seen this tradition of advocacy and leadership, starting with gay men in the early 80s, but extending to people in low and middle income countries. And I think that is the reason why over a very long period of time, we're seeing this global commitment to funding. And this just shows you the total amount of funding committed to HIV, starting in 1986, middle 80s were virtually nothing, and the number of organisations being established, initially UNAIDS, then the Global Fund to fight AIDS, TB and malaria, PEPFAR, an initiative from the US government under George Bush, so Republican government, to fund antiretroviral therapy in low-income countries. So a whole range of global organisations that have come together to fund what could have been a very major global crisis. In 2013, about $20 billion a year is invested in HIV. And if you look back over that period between 1986 to 2013, that's a pretty impressive way that resources have been put together. But actually, if you look over the last 6 years, funding has actually plateaued, and it's a little bit of a result of a successful story, because people think, oh, well, you know, you funded all this stuff in HIV, there's been all these advances, deaths are declining, new infections are declining, we should move our money elsewhere. But the thing is, if you move your money elsewhere with HIV, it's an infectious disease, communicable disease. If we start getting increasing numbers of people with HIV not on treatment, we'll get increasing transmission. So the work's not over yet, but maintaining that urgency that was there in the early decades of HIV is a lot more challenging. I should also say that there's heavy dependence on the United States. The United States probably accounts for about 80% of global funding for HIV, and that is also quite vulnerable, because I mentioned earlier the current administration are supportive of HIV funding, but of course that's not a given given many of their other political policies. So in the last few minutes, I'll just talk a bit more about science, not getting too technical, but you know, will we ever see the end of HIV? And I've talked to you about the role treatment has played and the role that biomedical prevention has played, and the decreasing numbers of people dying from HIV and numbers of new infections. But as a result of that, we have an increasing number of people living with HIV. And so until we have a vaccine and a cure, it's very unlikely we're going to see the end of HIV. And my own work has largely focused on whether we can have a cure for HIV and why we don't have a cure for HIV. And I'm going to talk to you just very little bit about what's being tried, because a lot of what's being done in cancer is very relevant to what is now being done in HIV towards elimination or getting a cure. So a lot of people first of all ask me why we even need one. I've just spent the last 40 minutes telling you about how good treatment is and increasing access, and you know, it's all over. But actually, there's still a lot of stigma related to HIV. If you still speak to people living with HIV across Australia who have a fully funded public health care system, have free drugs, they still talk about the incredible burden and stigma of living with HIV. In many parts of the world, access to treatment is not guaranteed. There is a cost. It may be reduced, but someone is copping the cost, as I've shown you, $20 billion a year to maintain current treatment levels. And there are some toxicities with lifelong treatment. And it's estimated that if we really want to reach the targets of 90% of people on treatment, we're going to require by 2030, $30 billion a year to sustain that. So this is a cost of maintaining, cost going to a particular illness that of course could be redirected elsewhere. If we had a cure, we may not have those ongoing costs. And just very briefly, when you, someone that living with HIV not on treatment, I mentioned earlier, you can measure exactly how much virus is in the plasma very accurately. High levels, around 1 million copies per mil. When you put people on treatment, the amount of virus decreases to what we call undetectable, or less than 20 copies per mil, and they're no longer infectious. But as soon as you stop the antiretroviral therapy, virus comes rapidly back. And the reason is that the virus can hide in certain resting T cells indefinitely in the body, and those hidden, what we call reservoirs of virus, are not visible to the immune system, and they're not visible to antiviral drugs. And so you have HIV going into hiding places which last indefinitely, and as soon as you stop the drug, the virus comes back. So all these people that we're treating will need to be on treatment lifelong. And we only have 2 cases of people cured from HIV. They both come from the cancer world. And although it's only two, these 2 cases caused tremendous excitement in the world, because it was proof of concept that HIV could be cured, because most people thought impossible to cure. I didn't mention earlier, but HIV actually becomes part of our own DNA, which is why you can't get rid of it. It integrates into our own genetic code. But there are 2 cases of cure. They came 10 years apart. The first one was in 2009, and this was in a man, actually an American man, his name's Timothy Brown, living in Berlin at the time, who got leukemia and required a transplant for his leukemia. And his doctor at the time knew that about 1% of people are naturally resistant to HIV, and they're resistant to HIV because they don't express a certain type of protein called CCR5 on the surface of their cells. And HIV needs CCR5 to enter a cell. And so in this first case, Timothy Brown, he had leukemia. He had received a bone marrow transplant from a donor that was CCR5 negative, and then stopped his antiretroviral therapy, and virus never came back. And no, there's a whole lot of ideas about why Timothy Brown was cured. Most likely it was the transplant, because his new immune system, or his new blood cell system, was resistant to HIV. So any virus that was left there couldn't go on to infect new cells. But there were a few other theories about what might have cured Timothy Brown. And then just 6 months ago, a second report from London, almost identical circumstances, except this time the man had Hodgkin's disease, not acute myeloid leukemia, also received a transplant from a donor that was naturally resistant to HIV or lacked the CCR5 receptor. Stopped antiretroviral therapy, virus hasn't come back for about 2 years. So early days still. Timothy Brown's definitely been cured for at least 10 years. And I love this quote. This is Timothy Brown, the first man cured of HIV. It's great that I finally have someone added to my family. It's been too long. And so although transplantation from a donor that's CCR5 negative is absolutely not a viable strategy to cure 37 million people living with HIV, it gives us a whole lot of new ideas to test scientifically that maybe this could be done in a simpler way. And these are some of the things being tested to cure HIV. So of course, gene therapy, I'll speak very briefly about that. Ways that you can target latency or virus elimination, immunotherapy with anti-PD-1 and many of the drugs that you will be familiar with to boost the immune response, or using a vaccine or antibody. And so gene therapy is being done for HIV. It was successfully done first about 8 years ago now, where people can have CCR5 removed from their genome using gene therapy or gene scissors. At the moment, this is being done ex vivo, so T cells have been taken out, modified, and then returned. And that allows for about 6% of gene-modified cells, not enough to stop the virus coming back. Now, if you can target gene scissors to CCR5, then you could potentially target gene scissors to HIV as well, also part of our genome. And this has been done and recently reported successfully in a mouse model, but gained a lot of publicity just about 3 weeks ago. So it's possible to do it in animal models. Human clinical trials haven't yet started, but there is companies developing this. There's one of them based in Philadelphia, Excision Biotherapeutics. Our own work has been seeing whether we can shock the virus out of its hiding place, so it then becomes visible to the immune system. And this is a representation of the virus sitting inside the DNA of a cell, effectively hidden from the immune system, and where we use drugs that potentially shock the virus, so therefore push the virus out of the cell to make it visible, and then this could lead to cell death or immune-mediated clearance. And this approach, which we call shock and kill, is done largely in people on antiretroviral therapy, so that any new virus you generate doesn't go on to infect uninfected cells. And we're looking at a whole lot of different drugs that can do this. Many of these drugs actually come from the cancer world, drugs such as histone deacetylase inhibitors, work we did with Ricky Johnson and others here at Peter Mac. And we know that latency reversal is possible in vivo. There are lots of drugs that can do it, in both in animal and human models. But we need better, more specific, less toxic drugs. And also, we still don't have agents that kill those cells. We can push the virus out of hiding, but those cells don't die. And so a lot of the work that we do is trying to discover new drugs that activate the virus better. This is one system where we have a screening system that looks at HIV activation, shown here in red, and non-specific activation, shown in green. This is work by Damien Purcell. You can use this screening cell line to look at lots and lots of drugs. The candidate drugs can then be tested in patient-derived cells, and we collect those cells by leukapheresis from people living with HIV at the Alfred. And through that approach have identified new compounds. This is a new compound which we did with Walter and Liza Hall Institute, imidazothiazoles that can activate HIV quite potently. We're also looking at new ways that you can deliver those drugs. This is with Frank Caruso, biomedical engineer, where you can use nanoparticles to get better delivery of those drugs to where the virus is hiding. But most likely, any drugs that shock the virus, or what we call latency reversal, will need to also be combined with something that kills the virus. And probably the most encouraging data came from the combination of using a drug to shock the virus, something called TLR7 agonist, with an antibody that then recognised that infected cell, and it led to depletion and cure of about 50% of monkeys that received that combination. And I wrote a news and views for that particular publication, and that combination is something that's now moving into clinical trials. And finally, some really interesting work that again we're doing with WeHi, Mark Pellegrini. Many of you will know about venetoclax, the wonder drug discovered by the team at WeHi. Well, we think that may also have a role in eliminating HIV-infected cells that express the molecule BCL2 that venetoclax inhibits. So just in the very last few minutes, I'll talk briefly about a similar sort of advocacy effort that's now being extended around HIV cure. This is led by the International AIDS Society, and we've been very active in advocating the need for that through a scientific roadmap, but also tracking and advocating for more funding in HIV cure research. This shows you the global funding for HIV cure work. $268 million in 2016, over $250 million of that came from the US government alone. Might sound like a lot of money, but it's far less than what is currently going towards HIV prevention research or developing a vaccine, about $1.13 billion. Many of us in the field believe that you've got to engage scientists in where HIV affects most, such as Africa. So we have a number of programs that are training both scientists and advocates in cure research. And we've recently partnered with the Bill and Melinda Gates Foundation to really see whether we can drive research and innovation actually in Africa, where most people are living with HIV. So can oncology use a similar model? Well, I'm really interested, perhaps this will be the subject of questions, of what can be done around pricing for drugs such as nivolumab or anti-PD-1, which have got a very high cost in high and income countries, but whether a similar model could be generated for costing in low and middle income countries. And there's also obviously a really important role that, that oncologists can play in capacity building and training. I'm really impressed by the program run out of Fred Hutch, Global Oncology. The man on the right there's Tom Aldrich, who I collaborate quite a bit with. For a long time, Fred Hutch have run a program of oncology and research and treatment in Uganda. Now their big focus is on immunotherapy, which can be delivered in a setting like Uganda, and whether that's an area that perhaps a place like VCCC could think more about, of whether there's a role that VCCC could play within our region. So finally, curing or eliminating an infectious disease is really tough work. It's only ever been done once, and that was for smallpox. In order to achieve elimination of smallpox, which actually happened on May the 8th, 1980, it took a highly effective vaccine and a global response mediated for the World Health Organization. So Australia, HIV is far from looking at this yet. It is something that we should be striving for. An effective vaccine and a cure could potentially one day see the end of HIV. But even without those big scientific advances, I hope I've shown you that there's a whole lot of other things that can really have a big impact, and they have already on the epidemic. And that is by testing more people, treating early, staying safe, meaning access to PrEP. And in that way, Australia might be able to end HIV. To end it globally, we still need a much more significant effort. So I've got about 10 minutes for questions, and I'm very happy to take any questions. Thanks very much.
Thanks very much, Sharon. Come over to the microphone. Thanks, Sharon, for that fantastic overview. We have some time for questions. And the first question here.
At one stage, there was a thought that generating antibodies to the TAC protein would be a useful strategy for developing effective vaccine. Is that progressing at all?
Antibodies have actually progressed. I didn't speak to them at all. They've been developed for vaccine development largely. So the most promising antibody development actually hasn't been towards TAT. So for those that don't know a lot about HIV, HIV's got a whole lot of different proteins. One of the proteins is expressed on the cell surface, that's the envelope protein. All viruses pretty much have an envelope protein, and it shows you that the virus is infected. TAT protein is a really important protein that drives the replication of HIV. And so if you're going to develop a vaccine to a virus, most people go for the envelope protein. So that's why the Hep B vaccine works really well, because you basically target the Hep B envelope protein. And the problem with HIV, though, is that HIV changes itself all the time, so the envelope protein changes all the time. So the real advance actually in antibodies has been discovering antibodies that recognize a whole range of envelope proteins, and they're called broadly neutralizing antibodies. And actually, people make those antibodies, they just make them too late to neutralize their own virus. So there's a real explosion of work on broadly neutralizing antibodies. You can generate them ex vivo to very large volumes, so people are using them as passive immunotherapy or passive administration. And there are now some advances of actually vaccination to allow generation of broadly neutralizing antibodies. So actually, I think antibodies do look really promising for vaccination, but it won't be, it's not for TAT, it's for the old-fashioned classical protein that we tend to target with viruses, which is envelope.
Another question?
Sharon, we remember when this wasn't even AIDS, it was some sort of immunodeficiency syndrome, and it's a remarkable story with so many positives. Now, you challenged oncology to take up the mantle. We can learn from the successes, but we can also learn from the mistakes. And I wonder, what have been the major mistakes perhaps over the last 10 or 15 years that have confronted the HIV community? And the work that's been done has obviously been very successful. What can we learn from the mistakes?
I think there certainly have been some mistakes, and they started early with engaging people affected by the illness. So this whole issue of consumer engagement and working with people that are affected by the disease actually started late in HIV. We now talk about these fantastic partnerships, but certainly in the US, people living with HIV or gay men were completely excluded from the conversation, which is what led to all the advocacy. And then I think that has been repeated again when you look at where people living with HIV are now. So 80% of people in low middle income countries. So I think if you start those conversations too late, it's not a good idea, because you're working on things that might be not relevant to people living with the illness. I think there's been big delays in getting advances into places that need it most. So we had antiretroviral therapy available to every Australian really in 1996, but yet that's only just happening in low middle income countries. So there have been these big delays. Look at PrEP. I mean, the science for PrEP was shown in 2010, and yet Australia, and again I always say this when I present stuff globally as well, Australia is this really incredible country. It's small, unified healthcare system, fully subsidised, relatively wealthy, and it's still taken 9 years to license in 2018. So there still is these really big delays. And I just bring it up around immunotherapy, largely because I know Grant is really interested, and he promised he'd be watching me somewhere, wherever he is now. But it seems to me that oncology treatment is getting easier with immunotherapy. I know it's not simple. I know it's difficult, but that may not need all this incredible fancy equipment or really extensive sort of monitoring that you need to do with very immunosuppressed people. So just thinking about what could, and I actually wanted to get the data for cancer deaths globally. What the best I could find was lung cancer being the 12th most common cause of death globally. So the burden of disease is not quite the same as HIV in low middle income countries. But still, you have to think, if we're getting really effective treatments now in cancer that are relatively easy to administer, what sort of infrastructure do you need to deliver it elsewhere? And I think with HIV, I've sort of compressed a 35-year-old story, but those gaps were quite long between evidence. And, this is evidence around I just take the PrEP example. You know, once you have an infected with HIV as a 20-year-old in Australia, you know, it's colours everything what you do about your, you know, relationships, who you tell, your medical care for the rest of your life, and lifelong treatment. You know, avoiding those infections are really important. We had the evidence to do that back in 2010.
Any additional questions? Sharon, could I just ask you, relating to the Eastern Europe situation, how do you think that can be addressed, or how do you think that can be impacted?
Yeah, it's a little unfair to lump all of Eastern Europe together. I did that because we can track infections by region. Most of it's actually in Russia. So I believe Ukraine and other parts of Eastern Europe do not have those sort of statistics. I think a lot of it is political, but there are political agencies within HIV that can exert pressure. I think exert pressure not by sanctions, etc. I mean, in the end, I think it's really important to work with countries, because you've got people living with HIV, you've got clinicians, scientists all wanting to reduce deaths and new infections. Political pressure, I think, can work. There was a UN high-level meeting for HIV in 2016. So the UN convenes all of its members around health very infrequently. So there's been a UN high-level meeting on antimicrobial resistance. There's one on TB, there's one on Ebola, but there's been a few on HIV, and that's probably a good forum for that sort of political pressure that you need around public health efforts are best by engaging communities, not disenfranchising them. So that's the sort of levels that I think it has to happen at.
Close to the home, how are things going in Papua New Guinea?
Papua New Guinea is at high risk for explosive levels of HIV. Papua New Guinea is poor, as you know, poor infrastructure, poor medical care, high rates of sexually transmitted infections, high rates of domestic violence, poverty, poor education of women. It's just ripe for a lot of HIV. And about 10 years ago, there were some worrying statistics that HIV was at extremely high levels. HIV, it's not at the levels that it was thought about 10 years ago. And I think but it's definitely at, probably about 10 times the level of what we would see in Australia. There's been some really good interventions there, actually largely led by the private sector. So a big company called Oil Search is largely responsible for implementing antiretroviral therapy in the country, not the actual government of Papua New Guinea. Interesting model, and that's largely because of an agency called the Global Fund that actually delivers antiretroviral therapy to low and middle income countries. So in fact, Papua New Guinea is not doing too badly on its, if you look at the increases in, if you look at the sort of pattern of notification and the implementation of antiretroviral therapy, but a country that would be at high risk.
Last question.
The importance of lowering the cost of treatment in low and middle income countries. But how was that actually achieved?
It was achieved through a change in patent law and drug pricing agreements with high income and low and middle income countries in the early 2000s. So that generic drug manufacturing, which normally can only happen once a patent has expired, which is, for people that are not familiar with this, it's 10 years for a patent to expire, was agreed to and allowed for HIV medications, and a similar approach is being used for hepatitis C medications, so that generic drugs were manufactured and legally sold if you're in a low and middle income country. In Australia, we can't purchase or procure generic medications until they're off patent. So it's a different pricing structure for low and middle income countries. But I'm sure it's relevant for immunotherapy. I think, though, that quality production of antibodies is a little different to small drug manufacturing for generic companies.
Thanks, Sharon. So I'd like to thank you for a fascinating and inspiring talk today. It's been a great privilege to hear of this journey over 30 years. Thank you very much.